Hi, Dirk. Hi, Giancarlo. We've been hearing the lectures, very incredible data, and especially Bill's TOBA talk was really interesting.
Thank you.
But we're ready to start here. We have an interesting case, and I know we're going to keep going because of time. I'd like to introduce our team. To my right is Dr. Vishal Kapoor, who's the director of Mount Sinai St. Luke's Endovascular. Next to him is Dr. Asma Khalik, who's our graduating endovascular fellow. She's going to be joining the Northwell group at Lenox Hill Hospital. Behind her is Ray Lascano, our endovascular MT, and behind him is Marichu Malloy. She's our endovascular nurse. And Asma, can you present the case?
Yes, so this is a 68-year-old gentleman who, 67-year-old gentleman who presented to us with
We have problems with the sound. Can you switch a little louder?
A little louder. Okay, I can present, Asma. I'll present it. So it's a 67-year-old male, Giancarlo, who's a history of hypertension, hyperlipidemia, and chronic venous reflux disease, is that it? Mm-hmm. Okay, and basically he presented with severe bilateral claudication to one of our referring physician, right greater than left, Rutherford grade 2, category 3. So he continues to smoke. Do you have another slide after this? Or ABI is done in the office, where right was 0.68 and left was 0.72 at rest. Next slide, please. So I think that's it, right?
Mm-hmm.
So basically, he has history of smoking. He's a current smoker, and he had been tried on community-based exercise therapy as well as silostazole, but not very compliant to either. So he had an angiogram done and was referred to us for this particular procedure, and I want to show you what exactly we found. So the left ear we're not worried about. So this is the iliac. So he has no inflow disease, just mild diffuse iliac disease. And the left SFA, on the right SFA, you can see he has via runoff a blunt stump occlusion, followed by some moderate to severe calcium in the mid-distal adductor canal segment, coming down, followed by just a single vessel runoff to the foot via the perineal. And you're going to see some DSA shots here. So here you have, again, I think you have to go next. Mm-hmm. So here you have the picture with the universal flush catheter at the level of the SFA. You can see a blunt occlusion. Next. You can see the reconstitution at the mid-distal zone. And actually, right there in the adductor canal. Next. And then you can see the popliteal is moderately diseased. There's a lot of movement here with the patient, so I apologize for the technical issues here. We just use conscious sedation. And then distal, obviously we have the anterior tibial occludes, the posterior tibial occludes, and the perineal is the single solitary runoff to the foot. So at this stage, this is a guy who's, we're concerned about his smoking. Obviously, we're going to do an endovascular procedure. We put him into smoking cessation programs. We've spoken to his internist, as well as we've involved social work here at Sinai. So the issue now becomes as far as relief of symptoms, he is quite symptomatic. I mean, he's a young man. He's active, and he's limited by his claudication. So he was referred to us for intervention. So I wanted to talk to you guys about what you thought of the angiogram, and then take it from there. From our perspective, what's really concerning is the beak. The way that beak is sort of like a flush occlusion makes us worry about a thrombotic component here. Inject, please. Makes us worry about a thrombotic component here. And so what we decided to do was use an angled catheter and use a 018 this is an 018 wire to try to cross this, and use a Connect 250T and see whether it crosses very easily, and then see whether our hunch was right. But I think this illustrates the cap like this. I think you have to be very suspicious. But I'm going to get started for the sake of time, and I'll let you guys tell me what you would do.
As support catheter.
See, it's already broke. It already broke.
Are you using a right coronary catheter?
So, Giancarlo, we're using the vert-tip catheter, and see, this is what was our suspicion. See, you can see that see how the wire is moving, and really it shows either a hibernating area or it shows maybe there's a thrombus in here. So what I'm doing is just going without the support catheter, but now I'll bring pardon my hand, I'm going to bring the support catheter down just because it's going really, really smooth without an issue. I think there might be a lot of thrombus burden here, and I think that's kind of the issue with the SFA in these type of occlusions. at this level, again, very smooth. Look at this.
It's just a
Come down.
micro channel thing.
Yep. Let's just take so, go ahead, picture. So in his history, he is a chronic claudican who was a smoker, and and if you see how the wire is passing with just an 018 wire, it's very surprising to me whether this is going to be all a layer of thrombus. And I think we all agree that the SFA does have, some level of thrombus in it when it chronically occludes like this. Hold on. Yep, this is definitely, now I got a cap. Yep. Nope,
There
we're
it
through.
is.
Look at that.
Nice.
So my question is, I think in demonstration purposes, now the decision becomes is, how are we dealing with this? I mean, we have this SFA that looked occluded, obviously wasn't, well, it's a micro channel here. I'm not able to get through. Give me an 018 catheter, guys. So I'm curious to
018
see what the
trailblazer.
panel thinks. I mean, when you encounter this, do you guys think there is thrombus here? And do you do some sort of suction thrombectomy, walk it out? Or how do you deal with this kind of situation?
So, Lawrence, please.
Oh, thanks, Giancarlo. PK, that's a great case so far. For these types of things, I think you have a fairly wide gambit of things you could use. You could use suction thrombectomy. Given the dual use of pathway, it may not be a bad choice to use Jetstream here. You could drill it, and then you can also aspirate it out.
So Lawrence, my question here is, when we have this kind of issue here, do you worry about filter protecting? You have single vessel runoff in the foot. I mean, the knee-jerk reflex, I guess, with any interventionalist, if it's that quick, is let's balloon, let's stent, and let's go. So here, my worry is that whether we have pockets of clot followed by pockets of occlusion. Like I think the area we're having trouble crossing right now is definitely an area which maybe above that will be a pocket of clot or a hibernation. So the question is, should we do intravascular ultrasound, like Aaron was talking about, and maybe he can comment on it to see how it is. I'm just curious what Dr. Yates or the others who over there also think about this.
Got it?
Yeah,
Wire.
that's, I think, an excellent question. Doing IVUS here, I think, could be very helpful to help identify areas where perhaps it's more hibernating versus the amount of clot burden. And that may actually direct your use of a filter in these cases as well. I think probably, given the length of this and the fact that there is likely thrombus, however, though, I think using a filter would be prudent, especially given the single vessel runoff.
Yeah, so the Terumo Navicross is not going either. I'm trying to get a Trailblazer down. We finally got one into the lab. So I think I'm just going to balloon this over here with a 4.0 balloon and then take a picture. Give me a 4.0 short balloon, please.
Certainly laser should be considered here, especially with the thrombus burden and the concern for intermittent lesions in there.
But would any of you filter protect this?
I would filter protect this, so single vessel runoff, long lesion, could be some significant clot burden. If you embolize something distally, it becomes a much longer and more challenging case. So once I cross, I'd put a filter down.
Now, Darren, you have so much experience with covered stents. Would this be a lesion with that runoff? Would you be concerned with using a covered stent in this type of lesion? You saw the runoff, and then the question of whether this is thrombus or not. There's clearly a stenosis here. This crossed.
Yeah, I mean, I don't think it's an unreasonable covered stent case, although with single vessel runoff, I think that your outcomes may be a little bit worse. But that being said, I mean, technically you're dealing with a long occlusion, and the data for other modalities are not necessarily that great. So that is a place where covered stents may have a role.
Okay. So we're just gonna. So right now, once we cross, I'm gonna put a filter down very quickly and do an intravascular ultrasound.
Give me an introducer.
I know sometimes we may do a lot of filters here. The reason we do, again, is I think it's rather than
Is the
chasing your
filter
tail,
ready?
it is an upfront cost, but I think it prevents us from having any trouble. Our filter of preference has really become the EmboShield. I mean, I think all the filters work well, but here with the EmboShield, we're able to use larger devices without worrying about the movement of the filter. So now that the wire is down, we're going to walk this out and quickly deploy the EmboShield and get the IVUS. And then we're going to decide, based on what the IVUS shows, whether to do an aspiration thrombectomy or would any of you just do an aspiration thrombectomy to start?
So PK, I think I would go directly with an aspiration thrombectomy because after you aspirate the clot, and then you do an IVUS, you can probably locate the stenotic lesions. So it looks like probably there's an acute and chronic kind of occlusion.
Yes.
Dr. Christian, this is Tim Yates from Miami Beach. I'd second that as well. I'd probably go directly with how quickly that cross. It's not unreasonable to characterize the lesions. Look for calcium. You had trouble crossing with the 035 catheter, sort of proximally. But a suction catheter here to sort of debulk and then reveal the critical lesion might be helpful.
I was wondering what the other guys think. You know, I've been using the penumbra quite a bit when it passes so easily. It's quite atraumatic, and you don't have so much vasovagal reactions as you see with the angiojet.
Yeah, I've used the penumbra in applications like this, and I think it does have a role. With the angiojet, typically you do embolize. I always use a filter if I'm going to angiojet something like this.
So then let's get the penumbra, guys. I'm just worried it won't cross that mid lesion, Darren.
Yeah.
You know, so I think what I'll do is
You may need to pre-dilate it with a small balloon
Yeah.
first.
Yeah, so now we have a
balloon?
filter down. I'm going to pre-dilate. Give me the 4-0 balloon, guys.
I think this is where the benefit of jet stream is
My
it
question,
can rotationally atherectomize that calcium, but still it has that thrombectomy code. Another filter that's kind of cool right now is this wire-on device. Have you heard about this? It's a wire that plugs onto any wire, or excuse me, a filter that plugs onto any wire that you have downstream, so you can use it on the robust part of the wire or the softer part of the wire, whatever you want.
I've seen it, but haven't used it.
Why?
Used it much?
Yeah, I was a part of one of the trial centers, but it's basically a door stopper. It's kind of an ingenious thing. You park it on the wire anywhere you want.
So we're just going to go ahead and
What
just
happened to
balloon
the
this one
nanocross?
area, which I
Nanocross,
was
4-0.
pleasantly, you know, it's when I saw the angio, it really was very suspicious to me. Did it cross?
Not yet, not yet, not yet, not yet,
Okay.
not yet.
It was very suspicious to me that
There it is.
this could be thrombus. So I'm just going to balloon this area here.
Go
Limit
forward.
my ballooning just to get a
Okay,
channel
top.
to do the
My remark
Down.
seems maybe a
Down, down.
little provocative, but after so many passes and so many different devices, what is the value of the protection?
Have you the penumbra already?
If you if you make an angiography, probably you have already a channel
right.
using a very old daughter technique. And now you are protecting.
So-
I don't know anymore what you are protecting.
So, you know, Giancarlo, that's a great point. We're going to take a picture now. Let's see what type of flow we have with the data. DSA, please.
Can you just, hey,
Because you're right. You know, we're protecting the distal vessel. We've dotted it quite well. Let's see whether we have any flow before we do anything else. See, we still don't have any flow. There, a little bit. Not really.
That, of course.
There it is. A little bit.
Yeah.
Put it in, put
It
another
depends where you are injecting. If you're injecting the stump, you will have flow.
So,
Okay, anyway, this is just
give me
my
another.
question. Why
Alice? No,
we
the penumbra.
practically we had
penumbra,
in the past extremely low peripheral embolization, relevant peripheral embolization, so that now the routine use of protection is for me a little too aggressive and very costly.
So PK, are you using a CAT6, a CAT8, or are you going to modify it with a MP guide catheter so you can twerk it around, get more lumen?
At this stage, Bhaskar, we're using a CAT6 device. We're going to go down and just run it once. And I kind of agree with Giancarlo here. See, it's not crossing. There it goes. Okay,
Ready?
let's start here, guys.
Okay.
I want to see whether we get the flow. So the CAT6 device, this device was really made more for you have to change this. So give me the right one, please.
Now what to?
No, it doesn't work. Give me the right one. So,
All right, he
so this
wants
was a
the
device
other
that
two.
was made for strokes and really has a good aspiration capability. So what we're going to do is we're going to go ahead and run it through the lesion and then see what we get. We might not get much, but I think it's worthwhile to capture what we can before we go ahead and do our final therapy. So the idea here would be is if that wire goes through like that, does that concern or the panel
All right,
enough
hold on, let me
to
turn it
do a thrombectomy, or am I being overkill here? Turn
Here,
it on.
now we have the,
Turn it on.
turn it on, it's on.
It's on.
Yes, go ahead.
Yeah, I think it's completely reasonable to do a thrombectomy. The question is whether or not this patient should be lysed if there's extensive clot. I guess the other question I would have, and maybe for those in the audience, the construction of the Cat 8 and the Cat 6 are quite
much
different.
No, we're not getting
And
any
as
fluff.
PK mentioned, the Cat 6 catheter tends to track fairly well, but is a little less has a little less body. The Cat 8 is an 8 French system, but is a little more robust, particularly for a peripheral application. So in this setting, I might opt, at least in our facility, we've gone to that as a first line in many situations, going with the 8 French system. Did you give any thought to that?
Well, I think the 8 French system, like right now we went with the 6. We had no aspiration. I think Giancarlo was absolutely right with all his experience. So I think, what we'll do at this stage is just go ahead and balloon angioplasty it and then decide what it is. I'm just going to go with an 01440 long balloon just to create a lumen, and then I have filter protection distally. 40 long, 014, please. And then we'll go ahead and take a good picture. So we've decided to take, no, I need long, 200,
200.
100, anything like that. And then we'll go ahead and take a picture. 014, please.
So that you don't have the Rotarex technology in your current lab.
No, unfortunately, Giancarlo, I know Dirk is telling me about that technology, that it's quite good. We don't have it. And I guess the question here would be, after doing this,
What is this?
if there is no thrombus and we just happen to cross via fenestration, I mean, what would the final therapy be? And I think we've got a lot of lectures here to talk about whether it would be a drug-coated balloon, because they've all been consented for drug-coated therapy, even in the face of the controversy, or would it just be a drug-coated stent?
And what about debulking system?
Does that add anything, Giancarlo? If we get good expansion with the balloon angioplasty, and we're able to get a nice 6.0 lumen with the data that Lawrence showed and the data that Bill showed with Imperial,
Okay.
would it matter for us to do any debulking here?
Okay, that's
Right?
fine. Go.
I would prefer to debulk because this is really a long lesion, and you can probably avoid some dissections. I think since your cross is very interluminal, and prevent really long
Back up,
stents.
please.
Yeah, that's what I do.
But would you not stent the whole
There,
segment?
it's down.
Is the question
No.
I guess I have. Is that okay? Yeah, that's the.
That's no problem.
Give me a little
I wanna see
die
the
just to
prop.
make sure.
Just want to see what the proximal is.
I mean, it really depends on what you're going to select as your therapy. If you've decided
Yeah.
that you're going to reline this either with a
Yeah,
covered
it's probably a
stent or
little
that
more.
it's a primary stent lesion,
Just
then there's
go
probably not a
a
big
little
role
more.
for debulking
Right
on
there.
this.
And
But
a
if
little
you're
more.
trying to avoid implants, then there certainly is a role.
Go forward. Okay,
But
good.
Darren,
Go up.
would you expect the patency to be good without lining this with some sort of scaffold? That's my question,
Need
right?
some more juice.
No, I personally would line it just because it's a long occlusion and you can see,
10,
areas of
12.
calcification kind of along the length, particularly in the distal SFA.
Yeah.
And so I think that there probably would be a benefit
We'll
to
come back a little
scaffolding,
bit.
and because it's a long occlusion, the data would suggest that it is something that we'd probably
Little
reline.
die up top. So for me, I think I purposely chose a small balloon because there we go. We already got flow. So I purposely chose a small balloon here just to see whether I can get away with limiting the amount of stent that I can do. I agree with you. I think distally I have to reline it. But with IVUS, this will definitely be bigger than a 4.0 vessel. So down. So I think this is just to create a channel and then maybe treat the proximal with drug and the distal with a stent. I don't know whether that would be a proper way to treat these type of long, challenging lesions. Walk it out.
Yes. No, leave it there.
You are dilating at the moment
Leave it negative, we just-
with a 4 mm balloon.
It's a 4 mm balloon just to get a channel, Giancarlo. We want to see, like you suggested, whether it's just all subtotal lesions or is there really any sort of thrombus now that we've distal protected. So we're going to run it now. This is the DSA. Nope. So it's really just subtotal all the way, but it's a diffuse lesion all the way down.
But then you can go ahead with a larger balloon and then use a drug-coated balloon.
Yep, I don't know in this type of severe calcium, especially distally, what do you guys think? And this is where we're going to use the IVUS. I want to run the IVUS down distally and really look at the level of dissection and what we see inside this vessel. And also obviously get an idea of what size drug-coated balloon to use rather than just eyeball it, which I know there's some question about balloon to artery ratios and also obviously what is it called, the the contact of the balloon to the arterial wall. Rail, please. So I'm going to go down now with the IVUS. Okay, can we go live on the IVUS, please, as soon as I go down? Okay, there's the IVUS coming down. Show me all the way down.
Yes.
All right, so we're distal, okay? This is after the lesion. I'm going to go forward. There you go. Okay, good. I'm pulling back now. Record, please. So that's probably our
Can
cap.
you put a tape? Look at this.
Yep, and you can see all that
Put
plaque.
a tape. Put a tape. Yeah.
So we were intraluminal most of the way, and I don't know whether there's a lot of, there seems to be some multiple areas of dissections, but there's obviously flow. But you can see how much calcium there is around this vessel. And yes, you know,
Right
I think Aaron's point, you know, IVUS does, you know, allow you to see what you want to do. I know here you see angiographic calcium. I'm curious to see proximal to this, right about here. So right about here, you were still in the calcified plaque. I'm going on floor as well. And right here, you could, angiographically, you don't really see much calcium, but IVUS-wise, you certainly do see a lot of fibrocalcific plaque within the vessel wall.
Right there.
Right there, a lot of plaque. There's another eccentric calcium at that level. Right there, you can see the calcium drop off. And then I'm just going to come all the way out. And that's now the native vessel, I'm sure, up top. Yep, there's the common femoral. So
Do you agree that you have a huge mixture between thrombotic calcification and fibrotic material, so that it is very difficult to give a clear answer? If I look to this IVUS, I can only say it is really difficult to decide what to do, because this is, in my opinion, is nothing for a thrombectomy, no more.
right,
And is nothing for atherectomy,
agreed.
and is beautiful for a balloon.
Okay,
And just go
what about the
ahead
distal?
with a balloon? Now, maybe distal you need a short stent at the end of the story.
DCB.
But this may be not necessary
6-0.
to, you have now a channel, and you have only to enlarge the channel, and now you have to choose to decide which technology you want to use. A mechanical, a thrombolytic, or
Rep.
I don't know which type of decision you intend to take.
Honestly, Giancarlo, I don't know either. I got to tell you,
Yeah.
that when I look at this, it really worries me, because we used to make these decisions without any imaging at all. And I'm curious to see, because we've got so many great people on the panel. You know, from my thought, just to give you my 2 cents, because that's what I'm going to be doing, I'm going to balloon angioplasty the distal. I have IVUS sizing that says it's a 6.7 millimeter vessel, so I'm going to use a 6.0 regular balloon up top just to expand. My idea would be not to stent the distal. Not to stent the proximal. Do drug-coated therapy. That's good right there. Do drug-coated therapy proximally and just put an alluvia distal. But if I dissect after this balloon, it'll change everything I do. So this is a 6.0 balloon, which is undersized for this vessel. So we're going to go to nominal, which is 8, and see how it expands. But I do agree. I do a lot of atherectomy, but in this case, I did not want to do atherectomy because of all the reasons. He's feeling the balloon,
Sorry.
so we're expanding it. There's a
Expanding
good
well,
expansion. Lo siento, señor.
Can we see the balloon in another plane? To be
Yes, sir. Yeah, makes sense. Here's the
PK,
balloon in the contralateral view. Yes?
PK, your Spanish is better than mine.
And there's 2 views right there. So it did expand quite well. Down. I'm just going to pull back. I'm trying not to get into that cap. A little die above, guys, so we can see. Okay, just to that. Just try not to get into the common femoral. Yep, a little more, a little more. Keep going. A little more. A little die, please.
That's it.
Yeah, go up there. So now Lawrence and Giancarlo on the panel. So if we do this, would we do another IVUS, or would you just say, based on what you see, just go ahead, stent it, or don't stent it?
Sorry, I know.
Lo siento, señor. Okay.
I think that angiographically, I would see what you see. I think if you do the IVUS, you're going to be impressed with how much dissection there is, and you may end up wanting to stent more than you have to. I think you're going to be obligated to stent that calcific plaque in the distal segment where the adductor is. I think the upstream segment seems to dilate easily.
Yeah.
I'd like to see what it looks like angiographically and maybe get away with, the challenged world today of DCBs notwithstanding, I still believe that there's going to be a role for it, however the panel ends up voting, but it'll be interesting to see how that plays out.
So what is the downside? Just want to play devil's advocate to using. I think Darren went over with the covered stent. It may not be an ideal case, but say doing an Alluvia or just a Supera without drug in this case. Oh, sorry.
Great choice for Supera, right? I mean,
Yeah, no, I think it's,
Calcium.
I think it's a great case for supera distally, particularly where that calcification is.
So now we ripped.
Because you see the dissections and you know that you're probably going to benefit from scaffolding through that region. I like the approach, and I'd probably, that being said, and things have changed a little bit since the Katsanos paper, but this would be something that we would treat with DCB and then probably use scaffold where it was calcified distally. And I'm not sure I would use a covered stent in this case just because of the single vessel runoff, although I do like using covered stents for long SFA occlusions.
I'm gonna play devil's advocate here, and I agree with you, Darren. I think it's great, but I think I'm gonna use Alluvia. I think that with the drug, the single vessel runoff, and the fact that their data is quite impressive, and they don't have they're not included in the meta-analysis. I think in this kind of case, I feel comfortable using Alluvia. I think this is the case where I think we're going to have to line the whole thing by looking at the angiogram, and the expansion of the balloon made me comfortable that I don't have to worry about it not expanding with the calcium. So I'm just going to go ahead and just go all the way to the distal and bring it all the way up to the top. I mean, I don't know whether you guys would agree, but it's kind of what we thought.
PK, you do what you need to do. The one alternative would be to tack it up with a prolonged balloon inflation, particularly in the front end of that, where it looked a little bit cleaner.
Okay.
But if you have to tack it up with a stent, then so be it. But I mean, the live case notwithstanding and the time frames of constraints that you're under, that might be an alternative, so you can get away with the DCB at the top. But
No worry.
No.
Yeah, so would you try to do prolonged ballooning and then and maybe use tacks instead of
potentially,
long
right?
stents potentially, or supera distal
But
and
prolonged
tacks
here is like
proximally?
5 minutes, which is an eternity on
Yeah.
a live case.
So can I ask you, what is the
think
resistance? I'm curious to see what Giancarlo thinks, and Darren, as well as Bhaskar and Dr. Yates, everybody on the panel. What, in the sense, what do you guys think about the Alluvia stent in these kind of this is a complex lesion, and the stent has performed very well in the trial, and also their long lesion registry also looks good. Go ahead, Dr. Kapoor is going to deploy it. What is the resistance to? I know we love supera and calcium, but in this kind of lesion where everything is expanded well with the balloon, why not use the Alluvia stent here? Do you think that this calcium is going to create some recoil?
How long is the longest Alluvia stent?
150, guys, right, or 120? Longest Alluvia is 120, I believe, at this stage. I might be wrong. I think it is 120, right?
It's 120.
But we had opportunity to listen today to results indicating that also for very long lesion, this stent seems to work very well.
Exactly. Yep.
But without stent fractures, and you don't have here very heavy calcification, so it is not absolutely necessary to use a superior stent.
One more.
So that, in my opinion, you can go ahead directly
Another 6.
with the Alluvia stent, and you have then the double effect of stent and drug, and because particularly in the proximal part you have a heavy dissection.
Yes.
But the advantage of this dissection is that it is a longitudinal dissection, and it's not a flow-limiting dissection.
So would we leave it? I mean, let me take another picture now. Let's really analyze this, because I think one of the difficulties we all face is not having you guys when we're doing these cases as to when you would decide to leave dissections alone. And I'm just going to take a picture here just to show you what the dissection looks like. So that's pretty nasty, Giancarlo.
Yes, but before you take the decision, personally, I would go ahead with a long balloon and inflate for 10 minutes.
Okay.
And then to see what happens.
Okay.
Because they are a mixture of dissection, thrombotic material, and but it is not a flow limiting dissection, so that maybe you can avoid the implantation of a ulterior stent if you have a long inflation.
So the question is, if you have a long, say you do a prolonged, and the dissection tacks up, our entire intervention is going to be dependent on the inflow. So my worry is at the level of the inflow cap, if I leave that, without stenting, I think that's going to be an issue. And I honestly, I think here, Giancarlo, I feel uncomfortable even with a 10-minute balloon inflation. I don't know, does the panel think I'll get a result? Because I'll stop and we'll do it offline and we'll show you what we did later if you guys really feel that we can tack this one up.
PK, it looks like the up at towards the ostium, you're creeping slowly back towards the ostium. I would be more concerned about even with a prolonged balloon inflation. I agree. I think stenting that is necessary. You don't want it to creep back into the common fem.
Yeah, I agree with the look of the ostium, the proximal. I would stent that.
Yeah, you have an intimal hematoma forming or an adventitial hematoma forming there.
What is that? Anybody else? I mean, because I'm really at a loss here because I could go either way. What about you, Darren? What do you think?
Yeah, I mean, you'd like to ideally to avoid, the full metal jacket and the SFA, but I agree. I mean, I think you have extensive dissection, and I share your concern with the proximal cap. I mean, I think you could balloon it and see what it looks like, but you may very well end up coming back and putting the stent in anyway.
Yeah.
So my other question was, we've seen that you take an angiogram 10 minutes later after balloon angioplasty, you see even more recoil. And so the question is, even if you tack it up with a balloon, what's the guarantee it's going to last for long? Or do you guys do a quick ultrasound at the end of the procedure to see what the flow is, if the signals are good, or do you do a pressure gradient pullback? Like, how do you assess the flow limitation? Is it purely angiography?
Let me,
Little die here, guys?
yeah, hold on, let me change it. 1 second, off fluoro.
Just a little die. Would you guys leave a gap between the two? And I'm curious about Dr. Bhaskar's question there. I think that's a great question. I mean, if you do leave it, do you assess with an ultrasound on the table, or how do you do it? Ready?
Yeah, I mean, I think you've already pulled out the IVUS and you have the catheter available. I mean, I'd look at it angiographically, and if I wasn't exactly sure what was going on, I wouldn't hesitate to drop the IVUS and get an additional image.
Look at the
Yeah,
dissection,
looks like it's gonna need to be a 3-stent case here.
Yeah,
So
yeah, and
I'm just-
I probably wouldn't leave a gap. So if you're going to do
Yeah.
that, I wouldn't leave just a 1 centimeter gap.
I
like that.
agree. I'm just gonna go ahead and stent it, and then I'll do the last stent offline to give Andre a little bit of time. So we're gonna go ahead and just deploy it right here. And how much do you guys overlap stents? I mean, is there any signs to that? I mean, in terms of how you make your decisions?
I think it depends on which stents you're using, because I personally,
Hold back.
with the alluvia, you're probably a couple of frames there, but with the supera, you would more do a kissing technique as opposed to overlap. I don't know how you guys do that if you do back-to-back superas.
I presume these are 7s, PKs, is that right?
These are 7s, my friend. Yeah, they're 70120s. And so, again, Lawrence, you can see the expansion is quite good. We do have to touch it up offline. And I think I'll do that offline. I'll take a picture now. And then I think this case illustrated some of the advantages of IVUS and how you got to watch out for. Maybe I did a little overkill there, like Giancarlo said, by going for the thrombectomy device early. But I think with a Rotarex type device, it would have helped me a lot more to pull out all this crud here and make this case maybe not have a full metal jacket. However, I got to tell you, this is a fantastic result. We'll tack that up. We'll put a stent up top, and I think the Alluvia stent has shown good data, at least in the intermediate term right now, and I'm confident that we can follow this guy out. Just a question to the panel: how long do you continue antiplatelet therapy on these patients?
Before you continue the therapy, I would like to see the peroneal artery.
Yep,
And the basket.
absolutely, totally agreed.
So PK, I would tell you that you just offered up a trick question, because the truth is these patients, even after you finish dual antiplatelet therapy, probably belong on Xarelto 2.5 twice daily with a baby aspirin after whatever 3 or 6 month process you're going to put them on.
Yeah, I'm always kind of intrigued by the idea
Much better.
of the Compass trial with
You have a
with
perfect
aspirin now
one
that
vessel
Ascent has
runoff.
come out.
No.
And now aspirin's, kind of person non grata. It'd be interesting if they did Compass again with Plavix, rivaroxaban.
Well, I'd classify this as a high-risk lesion, right? You got a guy who's still smoking and hasn't quit. He's got single vessel runoff, and you treated a very long total occlusion. So I think that single agent therapy is probably not adequate. I would have him on dual antiplatelet, or I think this is somebody to consider
So,
treatment with
I'm
Compass-like
sorry when
treatment
I
as Xarelto.
interrupt, but we have to switch to Leipzig
Yep,
because
perfect. Thank you, guys.
they are sent.
Thank
And
you.
thanks a lot for this. Great